Greetings to all of our AACP members, friends, and visitors. Today we have the pleasure of hosting Dr. Mayoor, Patel, and Dr. Carlos Vise. As you can see, this is a new webinar format, new platform, and will hopefully provide a much more streamlined webinar experience for all of our members. So any questions that you have can be posed over to the right in the chat section. So that's going to be an easier format for us to collaborate with questions and answers. Also, those are all going to be addressed at the end of the presentation by myself. Well, we will just jump right to Dr. Patel, who we do have the, we're lucky enough to have him here with us because he's got a presentation today that's going to be definitely applicable to not only what you guys are doing with your practice, but also looking forward to the future. So I guess we'll pass it off to you, Dr. Patel.
Sure.
Taking over.
All righty. All right, guys. Well, thank you for joining us. I know Carlos will probably chime in here shortly. Jordan, thank you very much for assisting us with this whole process here. It's wonderful to have someone that takes care of IT for us. My role was to kind of give you guys a nice topic on dentist role in sleep medicine, specifically when it comes to identifying our patients that we have within our practice. And the thing with this is, you know, we all seem to have a lot of passion and interest in trying to get these patients evaluated, diagnosed, and when necessary, also managed. But we may have a little bit of a shortfall when it comes to identifying those that might be at higher risk for it. So the best way to really start this off is we seem to come from a tendency of what one knows, one sees. So what we've been taught in school and all the things that we've been exposed to is pretty much how we look at the world, or in this case, how we look at our patients. Where I want to challenge you with this talk is conversely, what one does not know, one does not see. So hopefully by the time we get done with this presentation the next hour or so, you would walk away with some key pearls that maybe in the hindsight was not really pointing you in the direction that you may thought it was. And maybe with some of the evidence that I will show you, you kind of have a better understanding that it may demonstrate that some of these patients that we do evaluate may have some other issues that needs to be addressed. Now, if we look at it historically speaking, the problem we run into is the fact that through our education process, we really have not been given much opportunity to understand the upper airway. We're great and proficient when it comes to the soft tissues, looking for oral cancer in the mouth, looking at restoring the teeth, and all the things necessary in the upper airway. But we may have a little bit of a pitfall when it comes to identifying compromised airways and airways that may strongly support or suggest that these patients may be risk for sleep apnea. So we don't have the skill sets upon graduation to really get a good feel for it. I am sure this is changing, even though the statement I have made, as the new graduates come out of these programs, I'm sure a lot more emphasis is and will be given on airway. So to get you started, the picture on your left is basically a normal airway where you have what we call patency or an opening in the nasopharynx right behind the uvula. Okay. So with the airway, what we're looking at is when we look at the normal airway, we're looking for basically adequate space for the tongue to reside. Therefore, we don't have any constrictions, whether it be the oropharynx or the nasopharynx. The picture on your right demonstrates probably a patient that has some level of deficiency where the tongue occupies much more width than the space that's allowable, and as a result, leading to some level of obstruction, which not only encompasses the oropharynx, but also may take into consideration the nasopharynx, because of the approximation of the soft palates to the base of your tongue. So what we want to do is by the time we get done with this presentation, be in a position to look in people's mouths and suspect those that may have an airway that gets obstructed in the evenings, but the only way to really confirm that, of course, would be a diagnosis by a medical provider. Our goal, though, would be to screen these patients, find these patients. If we look at some of the prevalence data, 24% of men and 9% of females actually have obstructive sleep apnea. Now, that being said, not all of them will present with signs and symptoms that will point us in that direction. Where I'm going with this is 4% of men and 2% of females will actually complain of daytime tiredness, fatigueness, and have symptoms associated with it. This is obstructive sleep apnea syndrome. Okay, when we look at the word syndrome, there are symptoms associated with it, 4% men, 2% females. This discrepancy in numbers that you see also leads me to bring up one important point. if we go out asking all our patients if they're exhausted or tired, we will catch those that have possibly obstructive sleep apnea based on that questionnaire, but the numbers you'll be getting will be a very small fraction of the patient population. We need to rather identify those that may be at risk, may not know they have a problem because they may not present with significant clinical symptoms to warrant them to think they have a problem, educate them, and then get them on the road of possibly getting them diagnosed and or get them involved in their general health care. So if we look at signs and symptoms, and we just look at specific things that we typically would talk about, does one snore? Has someone watched you gasp for air while sleeping at night? Other things that may come up is excessive daytime sleepiness. Are you fatigued? Are you lethargic as the day progresses? Upon awakening, are you refreshed or unrefreshed? Maybe do you have depressive-like symptoms? These are some of the signs and symptoms that we could leverage off of. But do understand a lot of these conditions, specifically the tiredness, fatigueness, and depression, can be a result of other reasons as well. Now, men, if you look at signs and symptoms within the male population, males are more likely to have symptoms of snoring and, of course, observed apnea. In other words, a bed partner brings it to their attention. It's very rare for a man to walk in and say, "Doctor, I want to be treated because I stopped breathing at night. I witnessed it." No, it's more the bed partner's motivation to get the male populations addressed because of witness apneas and, of course, snoring being a disruptor for the bed partner. Females is a little bit more different. With females, what you're going to notice is some of the symptoms associated with apnea is probably more along the lines of depression and morning headaches. Now, when you look at morning headaches in a female patient population, especially if you're a general dentist just doing your day-to-day routine, our instinct would be, wow, morning headaches, you're a female, chances are you may be a Bruxer and have a temporomandibular joint problem. And as a result, I think you need a bite guard or a mouth guard of some sort to assist it. I need you to go with that with some caution, as I'll point out later down this presentation. And of course, with the depressive symptoms, it's not uncommon for these patients to be on antidepressants because the feeling of being depressed leading up to the primary care visits, more than likely being scripted for an antidepressant and therefore being managed for depression when truly it's possibly an airway issue. So when you see a female patient taking antidepressants, probably explore that history a little bit further. Now, most common risk factors are broken down into modifiable and non-modifiable. So modifiable are things that are common sense. You know, people that are overweight are more than likely to have it. People taking drugs, opioids, benzodiazepines, even I should put here muscle relaxants as an example. These are things that can actually worsen the airway, but by stopping or changing some of these prescriptions, that could abate it. Not consuming alcohol could be a factor here. Smoking, supine, sleep position, nasal congestion, and so forth. These are items that you could change. These are items that one could actually do and make some modifiable lifestyle changes to try and minimize the risk of having sleep apnea or improving sleep apnea. But then we also have another list, which is non-modifiable, the first being male gender. I make a joke, it is a joke, but you know, even though male gender is the gender that's at higher risk, I suppose with gender flipping that can be done nowadays, I'm not sure if that will change that. Totally a joke. Menopause status, something we'll talk about briefly. Craniofacial abnormalities, we're going to touch on that as well. Genetics has a role here. Definitely some races are at a higher risk for it, and aging, something that we can't really control. And these are non-modifiable risk factors. So these are situations where if you are planted with one of these items on your right, you're more than likely in those instances to be at high risk for having obstructive sleep apnea. Now with weight, and weight has been explored repetitively, it's been shown that overweight and obesity is definitely associated with obstructive sleep apnea. And if you take this into consideration and we bring up the male gender component, 2 to 3 greater risk in men than in women of having this condition. But if we try and understand why it's been proposed that the differences in men between men and females might just be the upper airway shape, definitely some level of the craniofacial morphology, and most importantly, the distribution of fat, affecting men much more so than females. But when we look at females, specifically that population that's in menopause status, do also take into consideration that total hysterectomies will put a younger female into menopause status, the risk of apnea does increase. So we need to take this into consideration when we visit or explore our patient's health history form. As mentioned earlier, genetics has a component here, about a 1.5 to 2 relative risk ratio of having this condition if mom, dad has it. Sometimes it's a situation where the kids may get identified of having this condition, and as a result, it's not uncommon to look up at the parents and see which one of them or both may have obstructive sleep apnea as well, purely based on the genetic component. And when we look at the genetics, we're looking at more of the craniofacial features that gets passed down, and probably also some of the neurological tone associated with the upper airway that may play a factor here. Smoking leads to upper airway edema, hence therefore constricting the upper airway. Therefore, in smokers, this is something to definitely have a discussion about. To try and open up the lumen space in the upper airway by reducing edema would require not to be smoking. Other conditions that we are aware of is alcohol consumption. It's not uncommon when you have a cocktail. Those evenings, you might get nudged a little bit more as a result of losing muscle tone. As a result of losing muscle tone, having a higher tendency of collapsibility taking place. And then as mentioned earlier, there are some medications that are notorious for this as well. One that we may prescribe quite commonly in a dental setting would be a muscle relaxant. So a patient that we suspect is at risk of having an upper airway issue, and in addition, we write them a muscle relaxant, we should proceed with some caution or revisit this from a different perspective. But the good thing is there's a lot of dental signs and symptoms that may point us in the direction of a patient potentially having some form of an upper airway issue. And we'll spend some time discussing these elements that we just that have just popped up for you. But let's look at it from another perspective. It's been reported that only approximately 10% of patients that have clinically significant sleep apnea syndromes have been recognized, which means there's a vast majority of these patients that have this but have yet to be identified. And I mean, at the end of the day, these patients do come to us at least twice a year. And we do spend at least 30 to 45 minutes, specifically from a dental hygiene perspective, looking at the upper airway. So if we're in a position that we have the opportunity of assessing the upper airway, we should also then be in a position to possibly screen our patients for this possible condition. So another question is, how do we go about screening? So there's a couple of things that can be done. Besides your intraoral exam, maybe some questionnaires just to kind of get the rapport going. So we'll start with the Epworth Sleepiness Scale. As you may be aware, the Epworth Sleepiness Scale, all it does is seeks for fatigue. It has no other value. It cannot quantify that the person actually has apnea, because do you understand, we know that one of the symptoms associated with apnea is fatigue, but only reported 4% of the time in men and 2% of the time in females. Hence, therefore, if we went with a high Epworth Sleepiness Scale to find all our patients, we'd probably find them, but those that score less than a specific number on the Epworth Sleepiness Scale may get missed, but yet have the condition. And this is based on asking 8 questions of lifestyle and then rating it on a 0-3 scale, 0 being not likely to doze off, 3 being a high chance. And these questions go along the lines of sitting and reading. What's the chance of you dozing off on a 0-3 scale? Watching TV, sitting inactive in a public place, such as a theater or a meeting, as a passenger in a car for an hour without a break, lying down to rest in the afternoon when circumstances permit, sitting and talking to someone, sitting quietly after lunch without alcohol, and in a car while stopped for a few minutes in traffic. And the number that you're looking for is anybody that scores more than an 11 would strongly support that they are fatigued, but not, once again, to say that those that score less than 11 don't have this problem. So the Epworth Sleepiness Scale is a question that we do utilize, especially from the standpoint of insurance purposes. But if we were using this primarily to depend on identifying these patients, we will probably miss a good bunch of them. So then what else can we use? Well, there's the STOP questionnaire, basically 4 parts to it. S, do you snore? T, are you tired? O, has anybody observed that you stop breathing at night? And P, are you hypertensive? 2 or more responses to the STOP, there's a good chance that the person may have mild to moderate apnea. But then there's an expanded portion of it called the BANG. And in the BANG, there's 4 additional questions that can be asked. BMI above 35, age over the age of 50, neck circumference greater than 17 inches in men, 16 inches in females, and of course, if you're male gender. The more yeses to the BANG in addition to the STOP, the higher the odds of possibly having moderate to severe apnea. So by using these 8 questionnaires, there's a good chance of you being able to identify some of your patients. There's also the Berlin questionnaire, broken down into some categories. The first category is all about snoring. as the patient answers these questions and checks these boxes, if the grid boxes where the answers are checked, you then tally that up on the lower aspect of these questionnaires. So the first section, category 1, is purely on snoring. Category 2 works on fatigue, and category 3 talks about hypertension. And what you would do down here is if in category 1, 2 or more of those positive responses were marked, you check that box off. In category 2, if once again 2 or more is marked off, you check that off. In category 3, this being hypertensive, if there is a history of hypertension, you check that box off. Any 2 or more categories, if they were checked off, there's a good likelihood the person has sleep-related breathing disorders, which basically warrants further investigation by a referral for testing and diagnosis. So there are some formal questionnaires that one could utilize in a clinical practice. But you can also just ask basic questions. And there's many basic questions just to kind of get the rapport going. And these are great questions for your hygienist to basically ask to your patients. So in a hygiene chair, as the patient's being taken care of, you can extrapolate some information pertaining to the person's sleep that can help you guide in your discussion when you do your final check on them. But another piece of paperwork that we utilize, but we may underappreciate, and we use it for different purposes, of course, is our health history questionnaire. We always take a health history questionnaire, and we use it for, is this person going to heal? Do we have to worry about prophylaxis with antibiotics, healing? Then the list goes on why we may look at a health history form. But there's some interesting data associated with some of the things that a patient may have, such as if they have a history of congestive heart failure, then there's a 60% chance they actually have obstructive sleep apnea. If they've had a stroke or a transient ischemic attack, then there's a chance 7% of the time that those patients have obstructive sleep apnea. Type 2 diabetes is at 65%. Drug resistance hypertension at 83%. Now, do understand, drug resistance hypertension strongly supports the phrase that they take more than 2 medications to control their blood pressure. But if they're just taking a hypertensive medication alone, it's 37% chance, or if they've had a history of coronary artery disease. So if we looked at our daily patient intake, how many times do we have patients that are diabetics and hypertensives that are in our chair for a routine dental check? There's a good chunk of your patient population that probably has some form of a sleep breathing disorder, but once again, has not been explored. So your health history form can be just as vital or critical when it comes to identifying these patients. But hey, at the end of the day, this is what we do, right? We look down people's throats, we look through the teeth, and we kind of get a sense of what's going on. And every one of these areas has a significant amount of clue that can point us in the right direction. So we'll explore these various areas and kind of get a sense of what's in these 5 general categories of the oral cavity that could strongly support that the individual may have some form of a sleep breathing disorder. But before we deep dive into it, let's just talk about the extraoral exam. And what I want you to appreciate is there's a couple things that need to happen for you to have an airway that can actually collapse. We need some factors that facilitate it. So the most common factor is basically skeletal. The bony enclosure, is it adequately developed? The second is, of course, a soft tissue that drapes over the bony enclosure. Is it excessive, such as a high BMI? And then let's not forget the gender factors. And of course, we've talked about weight being a variable as well. So we need significant number of variables and or factors to have a collapsible airway. Now, we all remember skulls from dental school, but we may have forgotten some basic principles. I like to, when I do this in a live audience, is pick out the practitioners and try and get them to answer these questions. So I'm just going to throw the question and, of course, just answer the question for you. My question to you is the floor of the orbit is formed by a specific bone that we deal with. That bone, interesting enough, is the maxilla. Now, if we looked at it closely, the maxilla also encompasses the floor of your nasal passage. Now, this will have some value here shortly, as I will show you in a second. But I just want you to remember that the floor of the orbit and the floor of your nasal passage is primarily the maxilla. And when we have craniofacial deficiencies, underdeveloped maxillas, in some instances, and I want to put this clearly, in some instances, an age needs to be taken into consideration. A prominent nasolabial groove will support underdevelopment. In today's world, when we see things of this sort, what do? We just put in some fillers and just pop that groove out. But in reality, what it's expressing is the soft tissue that's supposed to drape over the bony enclosure. There is a volume representation. Hence, therefore, you see these prominent grooves. As I mentioned, age needs to be a variable that needs to be taken into consideration, and it's not across the board, but still something to keep in the back of your mind. So if we look at Izuno's model, he talks about the fact that the airway size is predicted based on two variables and two factors. The first being the amount of soft tissue, which we will call here the BMI, anything less than 30, and then the bone enclosure, which is the craniofacial features, maxilla being the most important, followed by the mandible. Now, if we have adequate tissue, not excessive by any nature, adequately developed maxillofacial structures, you put the tissue over the bone, you've got an awesome airway. Really a good airway that's not going to be compromised. But then you have variables that take place where you might have someone that's overweight, and as a result of it, craniofacially was developed appropriately. Now you're going to have a compromised airway. And then the lower one represents a factor where you have someone that's not overweight by any means. However, craniofacially is underdeveloped. You put those two components together, we're going to have a compromised airway. Now, back when Izuno was looking at this, is primarily looking at it from an adult standpoint. But I want to throw this at you. What about this situation here where you have obesity in pediatrics, in children, and craniofacially underdeveloped? You can only imagine what the airway might look like in the pediatric population with these obese kids. Now, I told you that the nasal floor is the maxilla. So I want to bring up something here called nasal cycling. And nasal cycling basically is this. We never breathe through both nostrils at any one point in time. We breathe through one, and then we switch and we breathe through the other. And this is a normal physiological phenomenon, but there are some situations where this may not actually occur. So by understanding that and by knowing this, if we look at this lovely lady here, first thing I want you to look at is look at her eyes. Now you'll see that her right orbit might look a little bit more inferior to her left. And if we look inside her mouth and we look at the buccal flare of her maxilla, you'll see that possibly on the right side, it's not as flared out as it is on her left side. And if we drop to grid on the occlusal and we looked at it from the mesiolingual cusp to the midline, you'll see that on her right side, that width does not look as broad as it does on the left side. So here's someone that has a craniofacial disparity of some sort. And by getting her tested, we identify her as being a mild apneic. Now, what I want you to understand by this is, picture the scenario. When she takes air in through her right nostril, because it's underdeveloped based on what you see from the maxilla, and as mentioned, the maxilla will dictate the flow of your nasal passage, it's almost like her inhaling through a coffee stirrer. There's a lot more resistance, hence therefore there's a higher propensity of the soft tissues to try and collapse. And if you look at her left nostril, it's almost like being a slurpy straw, very easily able to flow air through it. Chances are that is it possible that craniofacial deficiency with some level of nasal resistance may be contributory to her apnea. She had no symptoms that she presented with, just these facial morphological features that led us to get her diagnosed. What about this gentleman right here? If you look at his left eye, looks a little bit more inferior than his right. We look inside his mouth, left side has a crossbite. Right? You get this gentleman tested and diagnosed. He classifies himself as severe sleep apnea. So there again, purely not based on symptoms, just craniofacial deficiencies leading us to getting them diagnosed and getting an understanding of what they may have. So our evaluation extraorally can also give us some value as far as what we might see intraorally. But this is what we're going to be faced with, our airway evaluation. And this is something that we deal with on a day-to-day basis, and we'll spend some time discussing every one of these components. So let's look at tonsillar tissue for a moment, and let's take an understanding of how we grade tonsillar tissue. So if we split the mouth into half, and you look at the lateral aspect of tonsillar tissue, if it occupies less than 25% within the pharyngeal wall, we call that grade 1. If it's about 50, it's about grade 2. At about 75%, it's about grade 3. And then when it's up to or approximates the midline, it's grade 4. And if the person does not have tonsils, they were removed, then we will classify them as grade 0. But what you'll see is as we have tonsillar tissue, we now have real estate that's being occupied by these meatballs that has really, at this point, very little value when it comes to getting air through some of these spaces. The first picture on the left is very little room for air to passage through. Here you've got some adequate space. And then the last picture is very compromised. So tonsil tissue or excessive tonsil tissue does take away from nasopharyngeal airway space, and that's something we need to take into consideration. But more importantly is the tongue. If we just have our patients open and we see where their tongue resides, if the top of the tongue is below the occlusal plane, there's a low chance of possibly having an airway issue. If it's at the occlusal plane, maybe a medium risk for it. And if it's above the occlusal plane, maybe a higher risk associated with it. But another classification system that may have a little bit more value is the Malapati classification system. And in this instance, when you have the patient jet their tongue out, you take a look at the oropharynx. And when you look at the oropharynx, what you're looking at is basically how much of the oropharynx can you see. So in class 1, you can see the entire oropharynx. Class 2, you've got the base of your tongue touching the uvula. At 3, the base of your tongue is at the soft palate. And at 4, it's at the hard palate. What's been looked at is the higher the classifications, such as class 3 and class 4, the greater the odds ratio of actually having obstructive sleep apnea. So there again, if you identified your patients purely based on Malapati classifications, you're more than likely to find quite a bit of them. And what does this look like clinically? The exam that is performed by a hygienist, just have them open, look at your tongue level without any further instructions, have them stick their tongue out prior to doing your oral cancer screening, and you get your Malapati classification. And then you want to finish off by looking at the tonsil tissue, in some instances sticking your finger or the back of the mirror. So you're inducing a slight gag, so the soft palate will rise, hence therefore you can pick up on it. And what we're looking at is this general area. So the top left picture, what you see is an uvula that's kind of edematous, kind of swollen. Top right picture, you've got the tonsil tissue and maybe a little bit of an elongated uvula. Bottom left picture, you have what we call a soft palate drape, where you really don't see the oropharynx because of the amount of soft palate that the individual has. And the picture in the bottom right, if you look at the lateral borders of the tongue, you've got some scalloping. And scalloping, of course, comes in very much different distinctions: deep, very obvious, or very subtle, like the picture in the top right. But there again, very indicative that there's not enough space for the tongue within the arches, in this instance, the mandible. Now, if we look at scalloping, and we looked at nothing more than if we just took these individuals and threw them in a sleep laboratory, 88% of them will actually test positive for having apnea, along with desaturations. So we do know that scalloping probably can be a very strong indicator. In this instance, when you see tongue scalloping, getting a good history on snoring or even sleep would be important. But with the predictability of probably identifying these patients with a higher likelihood of them having a condition purely based on scalloping. And there's some work done to kind of demonstrate this, that evidence of a lack of tongue space comes from examining the clinical features of the tongue. For example, scalloping of the tongue is associated with underdevelopment dental arches and strongly supportive and or suggestive of obstructive sleep apnea. And the only way you're going to know this is to get them tested. But the tongue itself also has some fat distribution that takes place. So when you put on weight, not only are you affecting the pharyngeal fat pads, that's on the lateral aspect of your airway, you're also affecting the tongue mass itself. And this dissectional study, what they basically found was a linear relationship that as body mass index increased, the tongue weight also increased, proportionally speaking. And when they dissected the anterior portion to the posterior aspect of the tongue, the vast majority of the weight was on the posterior aspect of the tongue. And this has some value because if that's the case, the posterior aspect of your tongue is the anterior wall of your airway. Hence, therefore, if you have excessive fat in the back of your tongue, it's going to kind of choke or pinch down your airway. So, BMI is important, but also understand that BMI can also affect the tongue itself. And there's been some other recent studies done looking at this from an MRI perspective, kind of pointing the same direction that in control subjects, we don't see as much fat in the lower aspect of the retroglossal area, as opposed to in apneics where there's quite a bit of fat associated with the tongue. So it's something to keep in the back of your mind when it comes to tongue itself. But there are other things that we see clinically as well, such as Taurus, and we also see exostosis. And both of them are strongly supportive and suggestive that there's something going on here. So if we look at just the general literature, and specifically when we look at it from the standpoint of Taurus, it's been speculated that we need some form of an external factor or external force, right? So there's got to be some form of force that needs to take place. And then, of course, the patient has to have the genes to express that bone. And if you look at anthropological studies, you see the same thing, that in mastoid hyperfunction, there was evidence of tooth wear, which is definitely correlated with some form of mandibular torus formation. So there's a historical representation that you need some level of force, which in our business will probably be along the lines of parafunctional kind of behavior, leading to the expression of tori. And what you'll find, and in this case, what you'll see clinically is most of these patients' airways are worse on their back, especially those that have tori, they're on their side. And you'll see this no matter what size these tori are, but you got to also respect the fact that these tori are taking away tongue space. And as a result of it, compromising the airway. So looking at tori is very, very important. There's very little that has been looked at by removing the tori. Is there a significant improvement in the airway? There's 1 or 2 papers that were published, but the papers were published along with maxillomandibular advancements. Hence, if it wasn't looked at as a standalone variable and or factor, so there's still some work that needs to be done, but it's still something that needs to be considered, that the extra space that's being occupied by this extra bony protuberance of some sort is going to take away tongue space and ultimately leading to the tongue regressing and probably compromising the airway. But another thing that's also clinically quite relevant is these non-carious cervical lesions. Many times we may blame the patients for brushing aggressively, and I would agree on the fact that if they had these lesions on all their teeth, as opposed to isolated teeth, then it may be something else that's driving it. And we do understand that this forced concentration that takes place at the cervical area because of clenching or parafunctional type behavior causes flexation of these teeth, leading to the loss of the hydroxyapatite crystals, leading to those lesions that we have identified. Which you also have seen clinically is when you try and restore those teeth, those restorations don't really last that long because the underlying factor has not been taken care of or has not been looked at. So there's been enough work to look at non-carious cervical lesions and wear on teeth and find a correlation that there is some factor that needs to be factored in. But if we reverse for a minute and ask the question, why is there this force taking place? There's kind of 2 papers that have looked at this. This paper right here basically induced in healthy individuals a hypercapnic situation. In other words, they increased CO2 levels in healthy individuals, but they had electrodes placed on the masseter and the genioglossus muscle. And as CO2 levels increased, they found that the masseter muscle fired, but as soon as the masseter muscle fired, the genioglossus muscle fired as well. And what they speculate is the genioglossus muscle is basically an airway dilator. For us to get air, the tongue has to move forward. But for the tongue to move forward, since it's attached to the geniotubercle on the mandible needs to be braced. And in this case, the elevator muscles need to be fired. So can it be that maybe clenching is driven due to hypercapnic type situations? And in this scenario, same researchers, but they looked at 10 healthy subjects once again. But this time what they did is they caused what they call inspiratory resistance loading, where they basically choke hold airflow. And they saw the same response, masseter fire followed by the genioglossus. And this kind of mimicking what might look like as apneic events that take place. So can it be that the forces on these teeth that we see in some of these patients are a result of hypercapnia? Or in this case, in this example here, an obstruction that's taking place, leading to a reflex to try and move the tongue forward in an effort to open up the airway and get the oxygen that we need. And what you'll find in cervical abfraction patients, when you get them tested, the vast majority will test positive for some form of an airway issue. So these are just examples from my general dentistry days, where finding these lesions, sending these patients off, getting them tested, and then coming back with various degrees of apnea, and of course, therefore managing it. Now, what about erosions on teeth? All right, specifically the linguals of the uppers, and in some cases you might see that pitting, hollow looking on the mandibular molars. And we know that gastroesophageal reflux, there is a strong correlation with it in obstructive sleep apnea. So there again, anybody that's taking proton pump inhibitors and or has a history of GERD and or clinically you see significant erosion in these teeth, you may want to explore that. Is it possible that apnea has not been diagnosed or not been appropriately managed leading up to it? And when you look at some of these patients' histories, like in this gentleman right here, hypertensive, heart disease, he's got a history of GERD. He's also telling you the fact that he snores, he stops breathing, no one's listening to him. We send him off, we get a study done, bingo, test positive for apnea. And this gentleman right here, he's got GERD and all the other things associated with it. However, he has had used the CPAP in the past. You get him re-diagnosed. You kind of pick up on the fact that, yes, still a concern that needs to be managed. So at least 80% of the population, or 3 out of 4 people, routinely wake up from sleep as a result of possibly GERD being a variable or a factor. Now, what about gag reflexes? All right, when your assistant or your hygienist comes to you with a wonderful impression and happens to also capture the vocal cords, my first question to the assistant would be, what happened to the patient? Not, oh, wow, you got a lovely impression here. Oh, please don't waste my material and overfill these trays. A loss of gag reflex can primarily be due to aggressive snoring. If you picture this for a moment, when you're snoring, the soft palate batters, similar to you banging your hand up against the table. After a period of time, your hand will probably go numb. In this instance, what you'll find in some of these patients, if they have a loss of gag reflex, there's no neurological reason to explain it. You want to maybe explore the fact that what's their snoring history like? Are they very loud, very aggressive? Because the soft palate, by it flattening and therefore diaphragmating, may lose that reflex and as a result, not have an intact gag reflex. So when you have impressions where you get a lot of material and the patient does not really gag, you need to question those patients. Now, this is extremely controversial when it comes to bicuspid extractions. There's various papers that have looked at this from one way or the other. Let's put it this way. In some patients, and I want to put this notion very clearly, some patients, when you remove these premolars, you're going to have a smaller arch. It's logic. You're going to take the anterior 6 teeth, you're going to push them slightly posteriorly. As a result, you're going to lose arch width. But as a result of losing arch width, we may increase the likelihood of not having adequate space for their tongue. Now, it is possible when they're younger, it's not a major fracture because of the tone that they may have in the upper airway. But as they age, can it be a variable? Can it be a potential problem? And you want to kind of lure to caution, but when you see bicuspid extraction cases, you want to explore a good sleep history and see, is there anything that can describe some of the symptoms they have or some of the medical conditions they may have that may be a result of not getting adequate air, possibly due to small, narrow arches. And if we look at some of the work done on class 2 malocclusions, it's interesting to note that when you look at class 1, class 2, division 1, and division 2, and we look at what we call the SNA point, where the maxilla is relative to the cranial base, all 3, the maxilla is exactly where it needs to be in a class 1 and a class 2 situation, right? So it's not like there's a deficiency of any form from the maxilla. But when we look at SMB specifically, you'll find that in class 2, division 1, and division 2, it's slightly retrognathic. So it's already supporting the fact that 80% of the time, most class 2 malocclusions are retrognathic mandible. And if that's the case, then why are we still taking teeth posteriorly? Why don't we develop these arches and bring the mandible more anteriorly? And this has been demonstrated in some studies to kind of show that there is some value to this. But in your bicuspid extraction cases, you'll find different facial profiles. And when you get these patients evaluated and addressed, you'll start picking up on the fact that some of them, depending on what the sleep history is like, have obstructive sleep apnea. In this study right here, looking at 16 young teenagers, what they basically did is they had class 2 malocclusions, they expanded them, they brought the mandible forward, and what you'll find is the SMB point, which is where the mandible is relative to the maxilla, there was a significant improvement as far as its positioning before treatment and after treatment. And as a result of it, when you look at the posterior airway space, there was also improvement in the posterior airway space. But what was much more, I guess, appreciative of this study was the fact that the RDI, the Respiratory Disturbance Index, at baseline, compared to 12 months post-treatment, had significantly improved to the point that these patients did not have an airway issue, purely based on developing the maxilla and bringing the mandible forward. So something to keep in the back of our mind that developing the arches is definitely a way to go in some of these patients. That brings you to deep bites or retrognathic mandibles, both of which are risk factors. Anything that's going to cause the mandible to be retroclined or retropositioned will increase the likelihood of possibly having a sleep breathing disorder, only because of the fact that the tongue attaches to it. Johal Amma looked at vaulted palates, and what he also found, both in males and females, a vaulted palate was basically a good indicator for an airway issue. So there again, vaulted palates strongly therefore supporting underdeveloped maxillas, leading therefore to nasal floors, hence therefore causing increased nasal resistance. probably being a very big factor when it comes to this. And of course, if the maxilla is underdeveloped, you know the mandible is underdeveloped. But sadly to say, the tongue has nowhere to sit then. All right, bruxism. So when you see bruxism, you know, the biggest thing here is often a TMD complaint or an etiology in some instances that's relevant to TMD disorders is parafunctional behavior. But you'll find that most people will also brux more on their back. If they brux more on their back, clinically, when you look at the sleep apnea in a patient that has normal weight or is obese or is mild obese, you'll find that apnea is primarily worse on their back than it is on their side. Now, if we look at this case here as an example, patient was referred to get restored, but you take a look at this gentleman right here. On his back, his apnea was 35.9. However, generally scoring here was a 25.4. Now, if you're going to restore this individual, that's fantastic. But if he's got apnea and bruxism may be a result of his apnea, whatever restorations you're going to place, it's probably not going to last. So in some instances, we want to take this into consideration. But it's also been proposed that even though we look at bruxism from a negative standpoint, that it's bad for an individual, can it possibly be that it's actually a good thing for the individual? And if I may read this out, they postulate, this is Simmons and Fern, postulate that the nocturnal bruxism may be a compensatory mechanism of the upper airway. Bruxism may help overcome upper airway obstruction by activation of the clenching muscles, which results in the mandible, bringing the mandible and therefore the tongue forward. Once again, very similar to those two studies that I described earlier, one on hypercapnia and the one on inspiratory resistance loading. And when we look at it from that perspective, is it possible that we see as far as destruction is probably an effect as a result of trying to protect the airway? So for what it's worth, keep this in the back of your mind when it comes to bruxism in patients, that is it potentially a result of a compromised airway. Now, you may also go down the road of looking at CBCTs, and there's been some work done looking at volumes as far as small areas, and you'll find that in apneics, you'll have a small cross-sectional area, and therefore compared to a control group and a non-control group and so forth, you do your volumetric scans and you'll find that, oh wow, you got a compromised airway, as you can see in the lower two images. But I want to point a note of caution here. These scans are done when the patient's awake. These scans are done with the patient upright. And also prior to maybe being asked if these scans were done laying down, would it show us any much more value? And the answer to that is no, the fact that the patient is awake. When the patient's awake, there's going to be some tone in this upper airway. So even though you may see a suspected compromised airway, yes, it's good to explore this further, but I don't want you to depend on scans to find your patients, because what you're going to run into is a risk as such. Look at these three scans right here. Huge airways, minimum cross-sectional area, the first one's 84.7. However, you get this gentleman tested, RDI of 22. You look at the next airway, you know, minimum cross-sectional 59.3. However, you get this person tested, adequate compromised airway. And if you look at this last one, yeah, minimum cross-section 186. I mean, it's a big airway, but when you get this person tested, has apnea. Now, when you see compromised airways, once again, I don't want you to hang your hat purely on the fact that the scans show these airways to be very nominal. It may increase the risk of them having it, but it does not exclude the ones that patients with large airways not having a problem. All right, so just keep them in the back of your mind. I want to thank Dr. Tamimi for using her slides, demonstrating that even head positioning can influence the volumetric measurement that you get. So this is her. She set herself in the machine, held herself in one position, got a scan done, basically went back, changed the head strap position for a moment, got the scan redone, and you can see there's a dramatic change in not just the volume, but also minimum cross-sectional area. So there's too many variables when it comes to the accuracy of looking at this type of data. Now, from a restorative standpoint, and you're in a situation where you have a restoration that happens to break, you know, go through a different hierarchy. Ask yourself different sets of questions. What was this patient's Epworth sleepiness score? Is this person overweight? Is this person a snorer? Is their tongue scalloping that I underappreciated? Is there craniofacial underdevelopment that I did not pay attention to? And was parafunction maybe the result of this? And say the answer is yes, 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 and yes. Then our next jump to the gun would be, all right, we know this person needs restorations. We know this person parafunctions. Let me stick them with the bite guard. I'll throw the bite guard in. However, I want you to understand that when you put a bite guard in, some of these patients already have compromised airways, you can actually make the airway much worse. Hence, therefore, raising the bite, in this case, occlusal splints, bite guards, or anything of that sort, can, in some individuals, make or worsen the airway. So we want to proceed with caution. If you suspect the person already has a compromised airway based on whether it be malapathy classification, lateral tongue scalping, craniofacial deficiency, Taurus, etc., 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 revisit this from a different perspective. Because in some cases, just by increasing vertical, which is the thickness of the occlusal guard, 80% of the time you may get an adverse effect where you make the airway much worse. In some cases, you might have patients already come to you and say, thank God you made me that white guard. I sleep so much better. You know, you pat yourself on the back, but is it possible that you actually had some positive effect in those individuals? And in maybe 17 or 20% of your patients, it has no impact, but you really don't know. So when you have a compromised airway and you need to put something in someone's mouth, you want to proceed with caution here. So let me just kind of sum this up and kind of walk you through this one more time. Look for asymmetries. I didn't talk about submandibular space, but basically if they have a double chin, there again, the likelihood of them possibly having an airway issue is probably high. Look for chronic allergies. Look for narrow nasal openings or nasal valve, things of that sort. Retrognathic mandibles, or the mandibles are shoved back a little bit. Neck circumference, there again, 17 inches or greater in males, 16 inches or greater in females, and a body mass index above 30. You know, these are some of those risk factors that we talked about earlier. So kind of look out for these. And then when you look at it from the intraoral perspective, we talked about the asymmetry of maxilla, which is the underdevelopment. The teeth, we talked about abfractions, facets, erosions. Soft palate, you got a high malapathy classification, a loss of gag reflex, the positioning of the uvula, edematous of the uvula, of course, tonsil tissue being a variable and a factor. Tongue, you got scalloping, tongue level, malapathy, once again, kind of depicting how much tongue you have within the archers. And when we look at the bone itself, you're looking at torides, exostosis, and things of that sort. Now, do note that dentists did not diagnose sleep disorder breathing. This is pretty much done by our medical colleagues. However, we are able to screen these patients, educate these patients, and make the appropriate referrals for diagnosis to take place. So I want to share a couple things that I did a couple years back, many years back, just to kind of show you how powerful this intraoral exam that we perform can be for our patients. So there was a year where I said, all right, if I'm not going to look at gender, I'm not going to look at age, I'm not going to look at BMI, I'm not going to look at any of these variables, I'm just going to look at intraoral factors and make some referrals and see what comes out of it. So here's an example. If they had scalloping, and if they had a malapathy classification of a 3 or a 4, and or a tongue level of medium or high, along with any one of these things, it could be a fraction, tooth wear, torides, any one of these components, I would write a referral to get them tested. Now, of course, do you understand not everybody follows through? So in 2010, I wrote just over 50 referrals consecutively based on the merit I just described, and 21 of them actually followed through and got themselves tested. Each one of these tests on this graph is a polysomnogram. None of these were home sleep testing. And the fourth one in is the only one that did not have a diagnosis of obstructive sleep apnea, whereas everybody else tested positive of obstructive sleep apnea. So I was like, wow, this is too good to be true. So in 2011, I repeated it. Once again, wrote a series of referrals, out of which 26 went in. In this year, this one right here, I'm not sure if you can see my mouse, that one, and this one right here are the only two that did not test positive for apnea, whereas everybody else did. This also was based on polysomnographic data. So where I'm going with this is kind of highlighting the fact that your intraoral exam is probably very strong and very predictive of finding your patients, educating your patients, hopefully them following through and getting themselves tested, and of course you therefore managing their condition if they're not able to tolerate conventional forms of treatment. I hope this has opened up your eyes. As mentioned earlier, what you would not see, you would not understand. I hopefully have shown you other things, other avenues, other ways to look at your patients, and kind of get you a little bit motivated once we get off this little COVID bandwagon, go back with full swing and get our patients taken care of. Thank you. Thank you.
Yes, thank you, Dr. Patel. In the meanwhile, we do actually have a few questions, if you wouldn't mind fielding those. So one of the questions we have is, in females, does the hip to waist ratio play a role in potential OSA?
Yes, it does. There's some literature to support that the hip to abdomen ratio does definitely play a significant role. So yes, that's another way of also screening. But I'd like to kind of lure to the fact that we are dentists. We should not be asking anything above and beyond what's in the face general area. So even though the medical literature does support it, I would strongly support that from our standpoint, we stay more focused from the neck up.
Okay. And would you be possible to pull up that slide of the dental signs and symptoms and
Sure.
kind of touch on that a little bit more?
Sure.
Well, he's looking for that. Can you hear me now this time around?
Yes, sir.
All right. Sorry about losing my audio at first. Thank you so much, Mayor. While you're looking for that slide, for another great presentation. You never disappoint. It was very insightful, very detailed. Really awesome presentation. Sorry I didn't get to introduce you, but I think most people know you very well. It kind of reinforces the fact that you're a recipient of the Hayden Stake Award. Mayor, you're one of our stars. Thank you very much for doing this for us. Let's get back to the questions. Can you hear me?
Yes, sir.
Yeah, you're good. Yeah.
So somebody asked also, Jordan, about this being recorded. Is this going to be on our YouTube channel later on?
Yes, sir. You should expect it to be on there. If not by Monday, definitely by Monday of next week.
Okay, great. Awesome. Please, when you go to the YouTube channel, do subscribe to our channel and click on the bell so you can get a notice whenever we upload another video, another great webinar like today's webinar.
Yeah, we do have a few more questions. What is if you want to get those, Dr. Vise, feel free.
Yes.
Yeah, you see them? Okay.
Yeah, I'm trying to look through them there. So somebody asked specifically, what do you do with a patient that's not complying with CPAP, Mayor?
Yeah, so those patients are not compliant with CPAP. Pretty much we get an order from their sleep physician or the primary care physician authorizing us to fabricate an oral appliance, evaluate these patients to make sure that they are a candidate for oral appliance, there's no contraindications for it, and then basically educate them on the risks and benefits of wearing such a device. And if they are willing to proceed, then of course the appropriate impressions, pairing up them with the right type of a device and taking over their care from the standpoint of just managing the apnea. Do you understand that when we take over their care, our job at that point is to make sure that there's no negative side effects taking place as a result of wearing it, and also encouraging that these patients follow through with their with their sleep physicians, since sleep is a chronic disease and it's not something that kind of will disappear per se. It needs to always have oversight, both from a dental standpoint, if an oral appliance is being fitted, and of course from the medical standpoint.
Okay. Here's another question. I think it would be good to get your perspective on this. There's a person that asks here, what is the limit of dentists in the treatment of sleep problems? How far do we go? He says, in my opinion, we can help the diagnosis, but it's not our responsibility to treat these patients. It is neurologists, psychologists, psychiatrists. I don't know if this person is a dentist or not, but I want to hear your perspective on it.
I mean, to be honest with you, our job truly is just to facilitate one thing, and that's to keep the oropharynx open. And we have the advantage of using dentition, using the teeth to make this happen. It's beyond our scope to diagnose these patients, and I do understand our frustration that we may have, but do also respect the fact that sleep is a very complex topic. We may bring up the word obstructive sleep apnea, but there's more than 70 different diagnoses one could potentially have that can, in some instances, be life-threatening if not appropriately diagnosed and or managed. So our role truly should just be get an order from a physician, facilitate the treatment. The treatment that we can provide, honestly, is just one form of treatment, and that's open up the airway using oral devices and leave it at that. Above and beyond that, the responsibility should fall back on the physician.
Okay, great. I've heard of some of the questions. I think somebody didn't know you well. I'm sorry I missed my introduction before because of technical problems, but for those of you guys that are not knowledgeable, don't know about Dr. Patel. Dr. Patel is one of the stars of the AACP. He's a diplomate of the American Board of Craniofacial Pain, the American Board of Dental Sleep Medicine, the American Board of Craniofacial Dental Sleep Medicine, the American, also the Academy of Integrative Pain, and the American Board of Orofacial Pain. He has multiple fellowships to mention. He's also, like I mentioned before, he's been the recipient of the Hayden Stack Award, which is given to for his extensive career as an educator in the fields of orofacial pain. And since 2014, Dr. Patel has been appointed the Director of Clinical Education for Near Practice Management. He's also a registered polysomnographic technologist. So if you guys are aware with the are you members of the AACP, probably have run into him. He is a great mentor and educator within our academy. Mayor, today it was another wonderful presentation. You never cease to surprise me with new information and new studies. It's always fascinating listening to you. I always learn every single time I listen to you. Thank you for a great presentation.
Well, thank you, Carlos. Thank you, Jordan, for this as well.
Yes, yeah, we appreciate having you on, and for everyone else that's in the channel, make sure you guys are staying up to date with what we have going on. This will be published, and so we'll have this on our YouTube channel, and I will shoot out a link to that when it's done being edited. And anything else from yourself, Dr. Vise?
No, just keep looking out on your emails, on your notices. We will be having some more webinars next week. So keep looking up. We're adding webinars as we speak, and we have a couple more, and it will keep you guys busy during this time if you're not seeing patients already.
Yeah. All right. Thank you, Dr. Patel. Thanks, Dr. Vise.
Thanks,
Thank
guys.
you, Mayor. It was a
Thank
pleasure
you,
to listen to you today. Take care.
All right.
No problem.